So I need to preface this talk by saying, as Margaret mentioned before, clinically I'm trained as an otologist, as an ENT, otologic surgeon. But from a research perspective, I'm much more an epidemiologist or a gerontologist. And I think this talk, as you'll hear today, is coming from a perspective as being a gerontologist and not as a clinician, actually. I think this will become clear in the next few slides. So I have to give some disclosures. I have several research grants from various agencies. I'm on the advisory board for two different pharmaceutical companies, nothing to do with this talk today. I do advise Cochlear about their studies of older adults, and I've given talks before at Amplifone and MED-EL-sponsored events. And I think this will not affect anything with this talk today at all. All right, so as an epidemiologist, I always have to start with a slide like this. If we look at the prevalence, how common a clinically significant hearing loss is, right? Basically a better ear, speech frequency, pure tone average greater than 25 dBs, a very, very sort of traditional, conventional definition threshold of hearing. And we look at the US population, we see that the prevalence, how common a hearing loss is, it basically doubles with every age, decade of life, right? I mean, this is something probably many of us recognize to some degree, but maybe not to this degree, right? This basically means by the time we look at our friends, family members, society that's 70 and above, that nearly 2/3, 2 of every 3 adults over 70 has a meaningful hearing impairment, right? Yet, at the same time, if we look at one of the most basic stepping stones of initial sort of hearing loss treatment per se, right? Just use of a hearing aid, right? And we look at people in their 50s, 60s, 70s, 80s, and the blue bars who has hearing loss, the red bars who just reports using hearing aid. We see that the use of just self-reporting using hearing aid is phenomenally low. It's about 15 to 20% of people who could possibly benefit. And I'll tell you, this figure, this percentage, this hasn't changed in 5 decades, right? Despite what many of us would say is our improvements in technology, I would say, right? Yet this number hasn't budged, right? So I think as a field, we always sort of wring our hands when they say, well, this is so terrible, and there's a stigma, and no one cares about hearing loss, right? But then if you put on your hat more as a public health scientist, I'll tell you it's not too surprising. And the reason for that is because you think about some of the most basic questions about hearing loss, some of the most basic questions that someone unrelated to the field would probably want to ask. You realize these questions now are just being answered or not even answered yet, right? So the first question, I mean, what are the consequences of hearing loss, right? If it's a usual process of aging, I mean, who cares, right? Are there any meaningful consequences beyond just like quality of life, for instance, right? Secondly, then, if we do think it makes a difference, what happens if you treat it? If we actually address hearing impairment through rehabilitative counseling, education, ALDs, hearing aids, cochlear implants, what have you, does that even make a difference on what we hope are some of these bigger outcomes, right? And finally, probably the third most important question, which is sort of nearest and dearest to my heart, is if we do think hearing is important, if we do think we can actually make a difference with our interventions, how do you even possibly intervene when 2/3 of everyone over 70 has a hearing impairment? There are quite simply not enough audiologists in this room or SLPs or hearing instrument specialists to possibly address this demand, right? So when you back up a little bit and you ask that these 3 basic questions are being unanswered, and they're unanswered still in many ways, it's actually not too surprising. Of course, hearing loss really isn't really addressed then. Why would it be, right? And the paradox here is this, is that if I showed any of you guys this audiogram, right, showing basically a mild, maybe hinging on a moderate sensorineural hearing loss, and I said this belonged to Jim or John, and he's 12 years old, I think everyone in this room would nod their head and say, this has to be addressed, right? So that's why in 20 out of 50 states now we cover hearing aids, right? And because we know this hearing impairment, this hearing impairment in terms of its impact on the child can impact how well the child can engage in the classroom, can incidentally learn on the playground, engage with family members and friends, right? And yet the amazing thing about this, though, if I told you all of a sudden now that John is now 72, right, with the same hearing impairment, right, the same potential functional impact upon communication, right? This could be a guy who's still working as an executive of a company. I could say probably even this room still, you might get a little more of a shrug saying, well, you know, you have a hearing loss, but you know, so is everyone else your age. If you want to do something about it, we can, right? Yet there's a fundamental paradox there, right? The same hearing impairment, the same functional impact per se in terms of how speech is encoded and how the brain can decode it, critically important for a 12-year-old child, and all of a sudden for 72-year-olds, who cares, right? And I think much of that has to do with these questions not being answered yet. Right? If you apply these same questions to children, I'll tell you, these are basically answered through many, many decades of research now. We know the impact of untreated hearing loss in children who are developing. We do, right? We know the impact of what happens when you treat it, right? And more importantly, we know how to address it societally, right? We have universal newborn hearing screening now for going on 15, 20 years now, right? So these questions have been answered in children in many degrees, right? But the same questions apply to the other side of the coin, other side of the age spectrum, are just now beginning to be answered, right? So these basic questions are what sort of dictates the sort of activities of my research group. And what I'd like to do over the next, I guess roughly 1 hour, we have a lot of time actually, is sort of take you through some of the progress we made and where I think sort of things are heading, right? And importantly, I should say this is a long sort of session, so by any means, I can't sit still for an hour. So if any of you want to ask questions in the middle of my talk, by all means, I more than welcome it, because otherwise this can get sort of droning on and on. Question already, all right.
Sorry, I just need a point of clarification going back to slide number 3, that prevalence, that you have it from age 12 on to 80. Mm-hmm. Yeah, that one. All right. Do you know, I assume that you are the author?
What, I'm sorry?
I assume that you are the author?
Yeah, that's me. Yeah.
Where's the source of this data, prevalence data?
So this
can you
data,
clarify where
this data is
got it?
from, it's called the National Health and Nutritional Examination Surveys,
Oh.
which are basically studies done by the U.S. government, CDC,
Yeah.
some of NIH.
Okay, I got it.
Yeah.
That one.
So
Okay.
basically, a reference. This is NHANES is basically a.
Okay.
They do these studies every 2 years. They basically take an entire sample of the entire U.S. population. They measure blood pressure, heart rate, get blood. Some years, many years now, they're doing pure tone audiometry. So basically conventional pure tonometry in a mobile booth that sits in this big trailer. Yeah, great question, thank you. All right, so what I'd like to do again today over the next hour or so, again, please chime in with questions whenever you guys like, is looking at these 3 questions and how, so at least my group so far has been addressing these, right? And the first one I'd like to talk about today is specifically what we think now may be the consequences of hearing loss in older adults, right? So I warned you about this before, and this is why I mention again, is that, again, my research fundamentally comes from my perspective as being a gerontologist and not an otologist. And what I mean by that distinction is that what I actually care about from the research perspective is actually this. I actually don't care about hearing loss directly at all. The reason why I do my research is because of this. I mean, this is the end-all, be-all for me in terms of what I care about, right? And I think healthy aging is a concept that all of us, you sort of know it when you see it. We've all heard this term before, right? So, for example, this is, does anyone know who this man is? Ah, all right. So there's some runners in this room, though, right? All right, this man should be your idol. This man is Fauja Singh, also nicknamed the Turban Tornado. He is 101 in this photograph, and I think now he's 103, still living in London, and he ran his last marathon when he was 100, right? And now he's officially retired, and I think he only does like 10 Ks, right? Yeah, it's really, really impressive. All right, so clearly a very vibrant, dynamic picture of healthy aging, undoubtedly, right? In contrast, an older man with mobility impairments in a nursing home, probably what many of us consider not to be sort of ideal or healthy aging, right? Contrast the top left, a grandmother interacting with her granddaughter on a daily basis, taking her to school, being home when she comes home. Clearly, I think many of us agree, a very vibrant picture of healthy aging. And finally, in contrast again, sort of the subject of today's talk and other people's talk today, is a woman with early dementia in a nursing home, probably what many of us consider not to be healthy aging, right? So importantly, I think from the research perspective then, we can define healthy aging by different facets or domains, right? Cognition, avoiding dementia, avoiding injury, falls, for instance, maintaining our physical mobility, right? All these different facets or domains per se of healthy aging, right? So a very basic question that I began to ask about several years ago now was asking very basically, does hearing loss, bread and butter, age-related hearing loss that all of us will develop to some degree as we age, right? Does it actually meaningfully contribute to these outcomes, right? And I think a natural question at this point, though, is, well, I mean, Frank, well, how do you get from hearing loss on the left, I mean, just some loss of hair cells or stria vascularis, degeneration from noise, how do you get from hearing loss to broader aspects of cognitive and physical functioning? Why could they possibly even be related, right? And I think a very natural response to that is, well, of course they're related, right? But it's only through some type of common pathological process, right? Namely, let's say aging, for instance, right? So as you age, you're more likely to have hearing loss from a variety of factors, right? And you're more likely to probably develop some impairments in cognitive and physical functioning, right? Or maybe things like cardiovascular disease, right? Hypertension, diabetes, smoking, right? Maybe education is a proxy of sort of life opportunities, right? So these things could all clearly link these two phenomena, right? But clearly, though, if there's all that links hearing loss with outcomes, right? I mean, who cares, right? Because it means no matter what we ever do as a field to prevent, treat, address hearing loss, we'll never make a difference on these much more important outcomes, right? Because it's purely just driven by a correlation, right? So a much more relevant question, of course, then is, well, are there in fact some mechanistic pathways through which hearing loss may directly impact these broader outcomes, such that hearing loss may in fact be a modifiable risk factor? So we address the hearing loss, could we actually make a difference on these broader outcomes? So to take you through some of the theory for how this has evolved now over the last 5 to 10 years in terms of these mechanistic pathways, I'll have to give one really brief primer slide, actually for the audience like this, but from an epidemiologic or gerontological standpoint, when I think about hearing, right, I think of hearing being comprised of just two very basic processes. I think of hearing being comprised of taking in a very, very complex auditory sound, composed of different frequencies, different intensities, all in real time. And the first step being the whole job of the cochlea is just to take in that signal and to encode it into a signal that then goes to the brain for decoding. Right? So purely from an engineering perspective, the cochlea encodes, the brain decodes. I mean, fundamentally, that's all hearing is in many ways, right? Encoding, decoding, right? So then when we think then about the classic presbycusis, age-related hearing loss that many of us will experience over time, clearly there are impairments in the cochlea, the stria vascularis, hair cells, maybe some spiral ganglion neurodegeneration, right? And in turn, that can clearly lead to quote-unquote hearing loss. And clearly by hearing loss, what we mean here is decreased sensitivity, so increased auditory thresholds, right? But clearly that's not the only thing. It's not just a threshold problem. The fundamental issue there is that there's distortion in sound encoding, right? So there's fundamental issues with how precisely, how crisply we can encode that sound that then ascends to the brain for decoding, right? And probably what many of us have heard described as is from our patients, right, is that it's very much as process effortful listening. Right? So you can still make out what's being heard, but it's just a little bit harder. It's a much more degraded signal sending, so you need to rely on other type of cues, the last word spoken, what the person's generally talking about, maybe some visual cues, right? And we've all been in this situation before, even quote-unquote normal hearing. If you're on a bad cell phone call walking down the street, you're struggling that much more to hear a little bit. You need to use more information and the context for what's being said, right? But what we can't forget, though, is this is what our daily existence is like if you have a hearing loss, right? So one pathway then through which has been invoked as possibly linking mechanistically hearing loss with some of these broader outcomes is very much the idea of cognitive load, right? Does the brain constantly have to rededicate resources, per se, to helping with hearing and decoding that very degraded auditory message, and has then come at the expense then of other systems? Right, so very much idea of sort of a cognitive dual task or load on the brain, right? And I'll tell you, this isn't a new idea. So Danny Kahneman, for those of you who know the name, won the Nobel Prize about 20 years ago. He's a psychologist and economist at Princeton. And 40 years ago, he formulated this idea of cognitive resource capacity, right? And it's a pretty intuitive idea. It's the idea that for any given one of us, any given time point, is that we have this pool of resources for thinking, memory, planning, what have you, right? And clearly over time now, based on many people's work, is we know there are likely some age-related decrements in this pool of resources, right? What we're increasingly understanding, though, is that hearing loss in and of itself may constantly lead to a constant load on the system as well, right? And hearing is fundamentally a very unique sensory system, right? It's arguably the only sensory system that we have, peripheral sensory system we have, that is always on. Right? You can't shut down your hearing, right? Even you're in the middle of the night, you're sleeping in a quiet room, you are still processing and decoding sound. It's just very much built into our essential evolutionary pathway that you have to be able to detect vibrations and sound to essentially survive. It's very, very rude. You're always processing sound whether you like it or not, right? So it's not something you shut off and turn on, right? It's a load that likely is always there, right? So importantly, this extends beyond just a theoretical idea now. So some really nice work, I'm just going to summarize one person's work, Jonathan Peel and Art Wingfield's group. This is more, Jonathan Peel was working as a postdoc, I think, with, postdoc? This was called postdoc with Art Wingfield at the time. But basically looking at functional MRI, so basically patterns of brain activation when given an auditory task, right? And if you take two groups of people who are otherwise age-matched, and some people have normal hearing, some people just have a mild to moderate hearing loss, And if you compare these people and you give them an auditory task, and you look at what part of the brains light up per se, what you see consistently is that people who have even a mild to moderate hearing loss compared to people with normal hearing is that with an auditory task is that they have reduced language-driven activity in the primary auditory cortex. And this is rationalized that if you have a very, very impoverished auditory signal sending, namely from hearing loss, that you actually get reduced activation in the primary auditory cortex, which it makes sense in many ways. What's interesting, though, and this comes from both their work and other people's work now, looking at high-density EEG now, other modalities for functional neuroimaging, is that what you see in these same people with hearing loss, though, is that you also see at the same time, which you don't see people with normal hearing, is what we think we're seeing is increased compensatory activation of the prefrontal cortex. So the prefrontal cortex, critical area for higher order processing, learning, things like that. And those exact areas appear to be being invoked or recruited to help with hearing, right? So very much giving a neuroimaging substrate, a functional neuroimaging substrate, this idea of cognitive load that we see, right? All right, so I'll tell you that's just one sort of distinct pathway which has been hypothesized. Another one which is very, very interrelated and sort of goes hand in hand with this in many ways, and which I'll touch on a little bit later, is the idea of does hearing loss in of itself lead to changes in brain structure and hence brain function? Right? And I'll go into this a little bit later, but one summary slide which I'll present here, and this is sort of some work that I've done with a woman called Marilyn Albert, who's a researcher at Hopkins, is if we look big picture now, big picture at the brain as we age, right? So it all stems from the brain, right? And if we look at some of the major hits on the brain, things that can quote unquote damage the brain over time pathologically, arguably two of the biggest ones, this is a little arguable, but I think many people would accept this, is probably early life or midlife vascular disease, microvascular disease, right? Small vessel disease can hurt the brain per se, as well as the classic Alzheimer's neuropathology from beta amyloid and tau, sort of later stage, things like that. Things that classically can damage a brain over time, right? So this has been pretty well established, right? Increasingly, what we've been hypothesizing, other people have been hypothesizing, is that hearing loss in of itself may act as an independent hit on the brain. Namely, if you constantly have reduced activation of the primary auditory cortex, does that lead to fundamental changes in terms of brain structure and hence changes in brain function? I'll show you some evidence that suggests this later, though, right? But very much idea of the hearing loss being sort of an independent second hit on the brain, independent of these other sort of more established pathology as well, right? The third pathway, which I'll mention now, which is not mutually exclusive from the other two, right? It's probably the most intuitive for people in this room, for any of us in this room, actually, for even society as a whole, is that hearing loss in some way, shape, or form can lead to loss of social engagement and some degree of social isolation, right? And it seems almost self-evident, right? Yet the amazing thing about this is that if we believe this as a field, if we believe this as a society, that hearing loss could affect our ability to engage socially, that is something fundamentally profound, right? Because I'll tell you, if you delve down to the gerontological literature, going back over 100 years now, since the days of a guy called Durkheim, we have long known that social isolation is arguably one of the most important predictors of morbidity and mortality in older adults, right? And I'll tell you, this is well studied, actually. Social epidemiologists study these pathways, and they're well established, that we know that people who are socially isolated as a whole, on average, have poor health behavioral pathways in terms of adherence to medical treatments, psychological pathways of self-esteem, self-efficacy. But what's probably the most fascinating work nowadays is increasingly looking at that there are physiologic manifestations too, where you actually see altered immune system reactivity and poor immune system function in people who are socially isolated, right? So this comes out of the work of a person called John Cacioppo in Chicago, where there's just a couple of studies now, where if you look at gene transcript profiles from leukocytes, white blood cells, of people who are socially isolated on top versus people who are socially integrated on the bottom, what you see consistently is that people who are socially isolated have upregulation of pro-inflammatory genes. And inflammation or aging in many ways is sort of the final common pathway for a lot of aging processes, right? So directly providing a physiologic substrate now for why for many, over a century now, we've long observed that social isolation is a very, very important predictor of morbidity and mortality in older adults, right? So in the end, we think that over and above any type of purely correlation or common cause pathway, that there are likely mechanistic pathways in place through which hearing impairment could actually meaningfully affect cognitive and physical functioning in older adults, right? So the question, of course, well, is this the case? I mean, yeah, these is hypothesized, but maybe it's really weak and you don't see anything really of substance, right? How strong are these mechanistic pathways per se that can lead to an association between between hearing loss over here and, let's say, cognitive and physical functioning. And when we began studies about 5, 6 years ago, one of the first outcomes we looked at in terms of all these different outcomes we care about and what we're going to focus on today is the issue of cognition and dementia, right? And Margaret sort of alluded to this later, I think just by the show of hands in this room for how many of us have been touched by dementia in some way, shape, or form. This is a big problem. And to put it in perspective, this is older data now coming from the Alzheimer's Disease Association. And if you look at the projected growth of number of people with dementia, and this is millions on the left, on the y-axis, of people with dementia over the next 40 years, it's astounding. And fundamentally, the reason for this is as all of us age, we can develop some degree of cognitive impairment, which for some of us may progress to dementia per se, right? And because everyone is living longer around the world, right? Mainly because the last 60 years of public health advances in terms of early cardiovascular disease, infectious disease, vaccination, everyone is fundamentally living longer to some degree. We're seeing that the growth of dementia is substantial, right? And to put this in perspective for the US, what's projected now relatively conservatively is that the number or the prevalence of dementia is basically going to double every 20 years until 2050. And what that effectively means, right, and this is relatively conservative actually, is that in 2050, 1 in 30 of every single living American will have dementia, right? So that's pretty staggering. Not 1/30 of older Americans, 1 in 30 of every single living American in 2050 is projected to have dementia based on current estimates right now, right? And yet, as probably many of you are aware to this day, every single major pharmacologic drug trial to reverse, prevent, even just delay the onset of dementia has not really worked, right? I mean, literally millions and millions of important this without a definitive therapy in sight right now for how to even just delay the onset of dementia, right? And it's important because even if we could just delay the onset of dementia by about a year or two, that has substantial implications for the prevalence down the road, right? All right. So with that in mind, then, when we begin studying sort of hearing and, say, cognition dementia, this is just a brief primer for an audience like this, is that there are many ways of measuring cognition, right? You can measure the different domains of cognition. I've only specified a few here, right? You have things like memory, which is pretty intuitive, executive function or attentional resource. If you're given two different streams of information, can you selectively pay attention to one over the other, right? They have also things like psychomotor speed, processing verbal function, visual spatial, but I'm never going to get to those, right? Importantly, I would say many people would probably agree to, and arguably, is that probably the two of the most important ones for our daily function are probably memory and executive function. So we're indicators of our daily function, right? Now, importantly, what I want to emphasize, though, is that when we measure these cognitive abilities, though, is that these tests are not dependent on hearing or auditory stimuli. Right? So if someone is, quote unquote, doing poorly on these tests, it's not because they can't hear the examiner. There are no auditory stimuli for many of these tests, right? So it's not being confounded simply by audibility per se, right? And importantly, I thought I show you what some of these tests look like just so that we can get a better feel for it. So a classic measure of executive function, trail making test part B, given a big sheet of paper with letters and numbers on it. And what you're asked to do is take a pencil and connect 1 to, where's 1? 1 to A, 2, B, 3, C. I mean, so it's a big sheet of paper, though, right? So clearly, you're juggling back and forth between two different streams of information, right? Clearly, no auditory stimuli, right? Another classic test called the Stroop Mix test, right? What you're asked to do here is interesting, is you need to name the ink color, not read the word, right? So, oh, this is embarrassing. Red, green, blue, right? I mean, so, as often as I give this talk, I still can't get it down smoothly. And the reason for that, of course, is because for all of us in this room, reading is completely an overlearned and automatic task, whereas naming ink color just is a little more unfamiliar. So again, suppressing something and doing something else, right? Clearly, again, non-auditory task of cognition, right? Finally, digit symbol test, sort of executive function, a little bit working memory, gets at, very simply, you're given a row of numbers, a row of codes, and you need to fill in the code as quickly as you can, right? So again, clearly non-auditory, no auditory stimuli in a task like this, right? All right, so for this initial sort of phase of research, basically what we relied on is doing epidemiologic studies. Right, so taking a large cohort or large groups of older adults who have been followed in the community, either just cross-section at one time point or followed for many, many years, right? And basically asking these large cohorts of older adults who are recruited from the community who have their hearing measured, have their cognition measured, have their blood pressure measured, all these things. In these cohorts do we see on average is greater hearing loss, again measured by the better ear speed frequency pure tone average based on pure tone audiometry, is that associated with poorer cognitive scores even after controlling or adjusting or accounting for things like age, diabetes, smoking, hypertension, right? So some of the first analysis we did many years ago was looking just first at cross-sectional studies, one snapshot, one time point. And some of the first data we looked at was something called from NHANES, again, the National Health Nutritional Examination Survey. It's basically a sample of the whole US population, several thousand people at a time who have a whole bunch of things measured, right? So this first analysis we did several years ago now, looking at only adults in their 60s. This is the range where hearing and cognition was both done, right? About 600 adults, all in their 60s, who had their hearing measured, had their cognition measured, and also where we adjusted for sort of everything on the bottom, their age, sex, race, education, diabetes, et cetera, right? And what you see on average in these analyses is that for every difference in age of 1 year, right, you see that on average, the DSS score has a lower score of about half a point. And that sort of makes sense. Age goes up, your digit score should go down a little bit, the cognitive score should go down. If you look now at a shift in 25 decibels in the pure tone average, basically going from a normal to a mild hearing loss roughly, you see that's associated about a 3.9 point score difference. So I mean, so what does that mean, right? How do you interpret that? And sort of the last column, if you look at the difference in age and years, that's approximately equivalent to a 25 decibel difference in hearing and it's associated with a cognition. It's about 7 years of aging, right? So it's actually not a very, very clinically meaningful effect as far as we can tell, right? Now, importantly, this is just one study. So the response that we got back then, well, Frank, this is interesting, but this is just one cross-sectional study, one exam, one test. I mean, maybe just a fluke, right? So we did the same analysis now in a completely independent data set. This is something called the BLSA, or the Baltimore Longitudinal Study of Aging. It's a long-standing longitudinal cohort of older adults followed at the National Institute on Aging, which is based in Baltimore for this one center, where they've been following many, many hundred people for literally decades. And we just initial cross-sectional sample again, so 347 adults, all older than 60, none of who at baseline in our analysis had dementia, right? We do the same analysis, but now we use two other cognitive tests. We use something called the Stroop mix you saw before and the trail-making test part B. Basically the same analysis. We see that the association with a difference in age in 1 year is this, with a 25 decibel hearing loss is this, and amazingly in many ways, across two completely independent data sets, three completely independent cognitive tests, is we're roughly seeing the same magnitude of association here, right? So importantly here, at this point, several years ago, the response we still got was, well, this is interesting. I mean, there's been some previous work suggesting this, but this is just cross-sectional data, right? You're averaging across people, you're measuring people at one time point, that's it. You're averaging, you're assuming one person with a hearing loss would behave like this if they had that hearing loss, et cetera. And the more convincing aspect is, well, they'll say, well, show me some more convincing data. By more convincing, let me show me longitudinal data. Show me some data now where you've been following people for many, many years. And you say, within a given person, those with greater hearing loss, do they actually have faster rates of decline over time, right? So this is the next set of analysis we did, and we turned to another data set at this point. This is called the Health ABC study, or the Health Aging and Body Composition study, also funded by the National Institute on Aging. About 2,000 older adults followed now for about 15 years, recruited from Memphis and Pittsburgh, just based on Medicare eligibility rolls, brought in every year annually for blood pressure, measures of physical functioning, blood tests, et cetera, MRI scans, as well as, coincidentally, fortunately, a measure of hearing, and also a very, very extensive neurocognitive battery as well. So I'm going to show you some of these results right here. So these are about 2,000 older adults, all older than 70, none of whom who had dementia at baseline, followed now for about 6 years with cognitive tests done basically every 2 years. And the summary data here, again, adjusted for everything on the bottom, this is just a summary results in the very end. If we look at a global measure of mental status, the modified mini mental state exam, so it does have a slight auditory component in terms of auditory verbal memory, right? But here the y-axis is higher scores are better, right? And x-axis is time, so year 5 is when hearing testing was done. And what you simply see is if you just break down hearing loss, no hearing loss, as in better than 25 dBs versus worse than 25 dBs, just a binary indicator of hearing, what you see is that at baseline, is that people with hearing loss on average have lower cognitive scores, right? Which makes sense with the previous data I showed you. Again, adjust for everything down here. And more importantly, what you see over about a 6-year period is about a 40% faster rate of decline on the 3MS over the 6-year period, right? Now, importantly, if you do the same analysis now, looking at the digit symbol test, which is completely, again, no auditory stimuli I showed you before, we see basically the same results. And this is just one summary figure. The reason I say that is because you can break down hearing loss. Don't keep it as just yes or no. You can treat it as a continuous variable. You have some, mild, moderate, severe. And what you clearly see then is you do see this dose-dependent effect, that the greater the severity of hearing loss up to a certain degree, the faster it declines. It's just hard to show on a figure here, so I'm not presenting those, right? All right. So you remember, though, I began this portion of the talk talking about how, yes, cognition is important, but the bigger issue is dementia, as we'll hear more about today. And just there are many ways to define dementia. I'm just going to tell you in terms of, from my perspective globally, I mean, just a very useful pragmatic definition of dementia is that it's not that you wake up one day and all of a sudden you have dementia, right? There's a degree, there's a prodrome where you have cognitive impairment for many, many years possibly. The key thing is when you tip over dementia per se, many of us would say that's roughly when it begins interfering with your daily activities, right? So that's when you sort of are defined as having dementia. And there are many, many different classification criteria for how you define dementia. And importantly then, if we think hearing loss is associated with a faster rate of cognitive decline, is it actually associated with a faster rate or a greater risk then of being diagnosed with dementia over time, right? Sort of extends itself, right? So this is what we looked at. So this is data again from the BLSA, the Baltimore Longitudinal Study of Aging. About 640 adults in the early to mid-90s who all had their hearing tested and who were basically followed every year to 2 years thereafter up essentially until 2010 when we did the study basically. And importantly, in the BLSA, when you diagnose with someone with dementia, it's based on a very, very adjudicated definition of dementia. This is based on the older, what's called NIN-CDS criteria back then, but this is based on a very adjudicated consensus-basis definition of dementia back then. It wasn't based on just one cognitive test, for instance. It was based on a consensus definition of when someone developed dementia, right? So importantly, if we look at this raw data, this is just called a Kaplan-Meier plot. The y-axis is the percentage of people who remain dementia-free. And the x-axis is basically a time from baseline, right? So obviously at time 0, when people join the study per se, or this analytic cohort, no one had dementia. I mean, that's why we include them in the study. And what you observe as you follow everyone for the next 15, 16 years, though, is that we see the progression or the progression to developing dementia being clearly related to the severity of your hearing loss at baseline. Now, importantly, this is unadjusted, though. We haven't adjusted yet for things like age, sex, diabetes, smoke, everything like that. So when you apply these models now where you begin adjusting for those possible correlational factors, the possible confounding factors, we see a very, very similar relationship, right? That compared to people with normal hearing, the risk of developing dementia, all-cause dementia, is basically this is called a hazard ratio, or basically gives a risk ratio. For people with a mild, a moderate, and severe hearing loss, roughly about twofold greater, threefold greater, and almost about fivefold greater. I mean, these are substantial risk ratios. We're not talking just a 5% increase in risk or anything like that. We're talking, theoretically, at least from this one study at least, an 89% increase in risk, a 200% increase, a 400% increase in risk. And I'm not going to show you this. This study has been replicated now in another cohort based in the UK, only on men, though, just that's how the study was designed back then, but roughly showing exactly almost the same risk ratios as well, actually. So very, very substantial risk ratios that we're observing, not a small clinical effect per se, right? Now, importantly here, though, when we published this several years ago, though, the response that we got back then from many people was that, yes, there clearly appears to be something there, right? That hearing loss does appear to be making a difference here, right? But what many people asked us still was, well, do you have more objective evidence? Namely, if you think that hearing loss possibly affects diagnoses of cognition and cognitive impairment and dementia, do you actually see hearing loss actually affecting the brain as well? Namely, a lot of times brain function follows with brain structure, not perfectly, but to some degree. Do you actually see that hearing loss actually affects the brain, right? So our hypothesis back then when we did the study, again with the BLSA data, is that we a priori hypothesized that hearing loss is associated specifically with accelerated atrophy, brain tissue loss, over the superior, the middle, and the inferior temporal gyri, the lateral parts of the temporal lobe, which are not classically the parts of the brain which are implicated in dementia. Those are more the mesial or the more the medial temporal lobe structures. But the reason why we hypothesize a priori is that if you look at the literature as a whole, right, those parts of the lateral temporal lobe are probably arguably the very, very important areas for auditory associations for how we process sound, right? So we're going to see atrophy anywhere, it should be namely in those areas, right? So the lateral temporal lobe, right? In particular, what we did was we used data again from the BLSA, so from Susan Resnick, who's at the BLSA, beginning in the early to mid-90s. This is remarkable back then, still remarkable to this day. They initiated a neuroimaging sub-study. So they took about 130 people who were all the healthiest of the healthy, Basically, I think only a couple of them had diabetes, some had hypertension, but a very, very healthy subcohort, and enrolled them back in the mid-90s into a neuroimaging study where they basically came back every 1 to 2 years for a brain MRI. And this is fundamentally unique almost to this day still in terms of the degree to which they have longitudinal data. Most neuroimaging studies you see nowadays in the literature are still based on cross-sectional data. You have MRIs at one time point, you have hearing one time point at best, and that's it. What the BLSA has done and still doing to this day is a longitudinal cohort, right? So we had about 126 people back then who had the hearing measured, who had MRI scans, and basically had average follow-up at least 6 years, MRI scans done almost every 1 to 2 years, basically about a total of 800 MRI scans. So it offers tremendous sort of power in looking at individual change over time, right? And importantly, if you look at this cohort of people, we just had to break down the normal hearing and having hearing loss just to make it easier because there weren't that many people, is that what you see is that the audiograms of the people are what you expect. I mean, normal hearing up there, and then this is the people with hearing loss. We're not talking like profound hearing loss. We're talking what we typically see in people who are 60, 70, 80, right? When we look at this data, I'm not going to summarize all this. Just neuroimaging data is a little boring to look at least a tabular format. I'm going to summarize in sort of one figure. Is that if we look at this, these are what we something called region of interest analyses. We can look region by region. You also do voxel-based analysis. We look at voxel by voxel, each little pixel of the brain per se. Is that exactly sort of hash out the way we thought for the most part. Is that we saw that hearing loss is very, very specifically associated with faster rates of atrophy over the lateral temporal lobe, again, the superior, the middle, inferior temporal gyri, and not the middle, the mesotemporal lobe structures. And specifically, and this is what we didn't expect though, it's primarily almost exclusively in the right temporal lobe and not the left, and I have no idea why, and I don't think any of us do yet at this point. I mean, it still needs to be replicated. But we did see this very, very clear specificity and association of hearing loss with faster rates of temporal lobe atrophy, specifically over the right lateral temporal lobe. And again, in terms of lateral, that we're honestly not sure, and this needs to be replicated. So, but we're seeing a very, very clear effect there. All right, so it gets down to this model too, which I talked about briefly before, the idea that hearing loss, independent of amyloid or the other classic pathologies, right, may be acting as sort of an independent hit on the brain in addition to these other pathways as well, right? Now, importantly though, so far I've only talked per se about cognition, and what Margaret alluded to is that over the last couple of years, other people from my group now have begun also exploring other domains or aspects of healthy aging, namely those same mechanistic pathways that we invoke for affecting cognition, namely cognitive load, brain structure, social isolation, could also clearly possibly influence other things as well, namely, for example, things like falls, right? So falls being, we take it for granted actually, but maintaining a bipedal stance and gait is actually very, very cognitively demanding. And you know this, if you're having a serious conversation on the phone or something like that, and you're walking, you actually slow your gait. So if you're trying to do mental arithmetic, you slow your gait speed, right? These are actually cognitively demanding processes. Does a cognitive load itself affect things like falls per se? And or in addition to having, this is interesting actually, we take it for granted, but when you are just walking along in a hallway, right, you are actually registering auditory cues, right? So literally, you could walk blindfolded down a hallway, and you can tell when you're passing a doorway. You don't think you can, but you actually can. So registering auditory stimuli and how that affects your gait and your balance is actually really hard to study. We think it makes a difference, but it's hard to study, mainly because you could put earmuffs on someone, but you still have the bone conduction. So you can't completely mask hearing in many ways. But yet our understanding now is that those very subtle auditory cues, though, are probably actually incredibly important for our gait and balance. So if you look at a variety of studies now, some longitudinal, some cross-sectional, showing a very, very nice clear association now between hearing loss, severity of your hearing loss, and your risk of developing falls over time, even after adjusting for all the confounding variables. If you look at broader aspects of mobility and physical functioning, your gait speed, for instance, your progression to disability based on established criteria, we're seeing very, very strong associations there as well. And if we even look at some broader health economic proxy measures, namely odds of hospitalization, actually even risk of hospitalization, we've done a longitudinal study now as well as mortality, as well as healthcare costs, we're seeing associations there as well, right? So importantly, though, I think it comes down to this, though. So if I put on my hat now as an epidemiologist, right, I'll say these results are fascinating. This sort of takes some areas of research in different directions where it hasn't gone before in terms of studying hearing loss as a quote-unquote modifiable risk factor. It opens up new areas of research, right? But then, so I get excited as an epidemiologist, right? But if I put on my hat now, let's say more specifically as a surgeon, right, I'll say, I don't care, right? Because show me that I can make a difference. Show me that I can address this and that makes a difference, and that's all I care about, right? Regardless of whichever mechanistic pathway we're going through, right? That's all that matters in the very end, right? So that gets at this question, right? So what is the evidence? What happens if you treat hearing loss? Does that actually make a difference, right? Unfortunately, though, this is the state of the science, right? The very, very fundamental basic question of whether if you address hearing impairment, you address it well, can you possibly delay the onset of cognitive decline or dementia? It remains completely, totally unanswered, right? They have one question here. So importantly, though, actually, let me ask you a question. That's your question first. Yeah, go for it.
Hi, just a quick question about the earlier work that you presented. So you presented 3 studies, all large groups, and you didn't indicate there if those folks were ever aided, or if
Great
you were
question.
just assuming the less than 25%, and also just thinking about it's likely that people with more hearing loss would be the people more likely to adopt hearing aids.
Great question. So key question. So basically, all these other previous cohort analyses I've shown you, on average, about 20% of the people who have had a hearing loss have actually used a hearing aid. So when you do this analysis, I never emphasize, I actually never show it for this reason, is that if you actually tease out hearing aid use, you look at people who have hearing loss, who use a hearing aid versus those who don't, do those people who just report using a hearing aid, right, do they do better? And they actually do, right? But I never show the data because you can't, at least from my perspective, you can't believe it, right? Because you can imagine among people who have hearing loss, those who choose to get hearing aids versus those who don't are fundamentally different. And they're 2 cross-competing biases, right? One bias is clear that people who choose to get hearing aids are the ones who are more affluent, right? The ones who are more health conscious, the ones who are more socially engaged to begin with. And that would all bias towards seeing a positive effect of hearing aids, irregardless of whether or not the hearing aid worked or not. At the same time, you have the cross-cutting bias, though, that usual people with a more severe hearing loss are the ones who got treated, which was sort of biased sort of against seeing an effect, right? You can tease that all you want. In the way I still won't believe it, though, right? Because I think there's so many factors there that affected that. I think it's going to be very, very hard to do. You can tease this out epidemiologically with what we call propensity score analysis like that. And it's being done right now. We're trying to do it. But the fundamental question in the end, I think, will never be answered with observational data. Because that's all, don't forget, these epidemiologic data sets, all they're asking is a one question. Do you use a hearing aid, right? Because nothing to do about whether it's properly fit, how many years you've been wearing it. Are you using it 1 year or 2 years? Are you using it for most of the day or not in the day? Do you have overall good communicative strategies? So there's so many other little nuances there that will never be teased apart from observational data, though. So that's why I say this has not been answered. I think the thing that's really needed to definitively answer this is a clinical trial, right, where you randomize that baseline, people who get treated versus don't treat it. Yeah.
This question is somewhat related, but it's addressing what you said here with a randomized clinical trial. I know the randomized clinical trial is really important in this sense, but it is extremely difficult to do. Also in public health, it has to be population-based. And randomized clinical trial tends to be more clinically centered. And I actually happens to work in public health too. Now, and this is the same problem on the other end of the spectrum, the universal newborn hearing screening, all right? In the sense that, when the USST, the preventative, when they actually judge whether newborn hearing screening is worthwhile to do, and they actually downgrade to grade B. Because of this, there's no randomized clinical trial. Even until now, it is extremely difficult to pull off a randomized clinical trial in the other spectrum that hearing aids actually made a difference. All right, so in a sense of that, how do you get around this for the adult population?
So give me 2 slides. All right, so I think what she was getting at fundamentally, yes, sometimes clinical trials are really, really hard to do. Even beyond, I think what you touched on briefly too is that a clinical trial shows efficacy if you do everything perfectly in a clinic-based setting, but we're still not even getting it at effectiveness in terms of broad-based, real populations, audiologists out in the field, things like that. Two different questions. Usually they start with efficacy and then you go to effectiveness, hopefully. But all right, to your point though, right? First of all, the reason why I even care about this, I think why many people are beginning to care about this in many ways, is that if we think about these mechanistic pathways that could possibly link hearing loss with cognition dementia, right, is that increasingly we're understanding that, at least as far as we're concerned, is that as we think about our interventions, best practice, sensory management, counseling, rehabilitation, sensory management with amplification, things like that, is that as far as we can tell now based on what we know about our field and field science, per se, what hearing intervention can do, is that they could plausibly actually impact these pathways, right? And that's the key, right? We clearly hope with a good hearing loss intervention that we can reduce the cognitive load of processing degraded sound. If we can send a clear signal on average, right, we hope that we reduce the cognitive load of that, right? Secondly, we clearly hope we're providing increased auditory brain stimulation for what it's worth, right? And finally, clearly, the sine qua non for a lot of us is can we hopefully improve social engagement and communication, right? So the idea of treating hearing loss could theoretically impact these mechanistic pathways. That's very, very important, right? So importantly to that end, though, I think the reason why this just overall idea of hearing loss and cognition dementia has gotten some attention, though, is because the important thing about hearing loss here is, as we're understanding it now, theoretically, though, is that it's potentially a modifiable late life risk factor for cognitive decline dementia. And what I mean by that, if you look at some of the most important, arguably modifiable risk factors for cognitive decline dementia right now, they are probably things like midlife vascular disease, things like diabetes, hypertension control in midlife, right? Namely, if you wait till someone's 70 before you treat their diabetes and hypertension, it's sort of too little too late, right? But if you can treat it in midlife, when they're 50s and early 60s, it makes a big difference, right? And that's actually, interestingly, why this is one theory, at least, that if you actually look at the absolute risk of dementia nowadays, right, it actually may be going down a little bit, right? The numbers are still going up, there are more people who are older, but the absolute risk of individual adult may be going down a little bit now compared to a couple decades ago. And one thought process behind that is that we may be catching up now to the cardiovascular interventions we started 20 years ago to better controlling hypertension and cardiovascular disease, right? So anyway, but the problem with those, though, I should say the problem with that, but you have to intervene upon those in midlife, right? You get every 20 years to happen. Our understanding about hearing loss right now, I guess on a theoretical basis, though, is that it may be potentially modifiable in late life, which makes it a very, very attractive target then for public health interventions because you can still intervene. It's not too late per se. And more importantly, you buttress that against the fact that any type of hearing loss intervention, I guess short of a cochlear implant, is fundamentally no risk. I mean, there's absolutely no risk with treating someone's hearing loss. There's only possibly upside for the most part, many people would argue. All right. So with that in mind, to your point, well, what about the clinical trial? So this is where we're going right now. So we have the initial phase of funding for the National Institute on Aging to develop this exact clinical trial. So conceptually, it's called the ACHIEVE trial, the Aging, Cognition, and Hearing Evaluation in Elders, or the ACHIEVE Healthy Aging trial. And it's being done in collaboration with a lot of people across the US, right? We're following the design of this study. It looks like this, is that at baseline, we're taking 70 to 84-year-old adults with mild to moderate hearing loss with no cognitive impairment, randomizing at baseline to basically best practices hearing rehabilitation as defined and being manualized by Terry Chisholm's groups at the University of South Florida. So basically, hearing treatment as it should be done. Basically, counseling, sensory management, fitting of devices, education, not really auditory training, but ACE therapy, so Luz Hickson's work looking at just communicative strategies, things like that. Randomize people to that at baseline versus a successful aging control, which is basically an established program based at the University of Pittsburgh, which is basically these individual instructor or clinician one-on-one interactions with a participant going over healthy aging topics, nutrition, diet, exercise, things like that, right? Which has been shown to seniors, older adults actually like this a lot. So randomize at baseline to one of these interventions, right? Proximal outcomes looking at things like audibility, speech, environmental sounds, obviously, as well as communication, social engagement, but really being powered over a 3 to 5 year period looking at rates of cognitive decline. Can we actually reduce the rate of cognitive decline, possibly reduce the risk of dementia, really powering on cognitive decline in this cohort, though, as well as looking at a host of secondary outcome measures, looking at things like mobility, daily functioning, brain MRI, hopefully as well if we can get it funded, as well as social activities, right? Now, importantly, this trial, much to your point, Well, how do you operationalize a trial like this? So this is where efficient science is key and collaboration is key. So there's a study called the ERIC study, the Atherosclerosis Risk and Community Studies, a 16,000 person cohort study, began in 1987 at 4 different centers across the United States. So people back then were 40 to 60 years old, and now been followed now on average about 5 visits over the last 25 years, right? Where every year, every 5 years on average, they've been coming back for neurocognitive batteries, measure vascular blood pressure, a whole bunch of things. The initial phase of the study was being powered to really look at midlife vascular disease and how it is associated with later life cardiovascular events. And there have literally, I think, been 1,300 papers published out of this cohort already. So what we've been doing over the last few years now is teaming up with the ERIC cohort is our clinical trial will be nested within the existing ERIC cohort. So taking a subsample of there are about 6,000 people who are still surviving, taking a subsample of those and doing the clinical trial on these folks. So operationalizing across these 4 community-based cohorts across the United States going forward. Now, the reason why this is important, and this is key, right, is because if you'd recruited a completely de novo cohort, you could, right? But then you have 4 measures, right? You have their baseline measure of cognition and hearing, obviously, too. And then you have annually their measure of cognition at years 1, 2, and 3. So you can look at these individual trajectories over time. And what you hope to see, obviously, is that people who treat a hearing loss, it's flatter, and people who don't get treated, maybe it's a little more steep, right? That's what you hypothesize, right? But you're fundamentally basing that change on basically essentially 4 data points, the baseline and then years 1, 2, and 3. In ERIC, the beautiful thing about ERIC, though, is people have been followed for 25 years, right? So we know their preceding 25-year trajectory of cognitive function to begin with, right? So it makes it far more powerful if we're looking for an inflection point. So basically looking at 25 years goes like this, do we change the inflection point for what they're doing now once we begin addressing hearing loss? So it makes for a very, very efficient science here, not only in terms of logistically, in terms of operationalizing a study like this across 4 different sites and things like that, but more importantly from a scientific perspective too, it makes it far more efficient and far more powerful as well. So just a brief overview of what this RCT is doing right now. For the last year and a half now, or last year, I guess, we've been funded under, it's a weird grant, it's a clinical trial planning grant process from the NIA, which basically just allows us to do the development of protocols, operations manuals, the pilot study being funded actually by another grant though, but just operationalizing the whole process. It takes literally about a year and a half, 2 years. Next year, we'll submit for the complete trial grant, which is a bit of a monster. From there, about 2 years of recruitment, and from there, about 3 to 4 years of follow-up, though, right? Right now, it's being powered roughly about 766 people, 70 to 84 years old. Again, healthy, cognitively normal, community-based sample. Intervention, again, is the best practices hearing rehab versus a successful agent control group. And finally, we're being powered to about a 0.25 effect size and rates of cognitive decline over time, right? All right, so actually, I should pause it, but so this, I get very excited about this in many ways, but for me, it's also a little bit daunting in a way, right? Because what you're fundamentally doing is a primary prevention trial for cognitive decline, which means the earliest we'll have results from a study like this, assuming it gets funded in the first round next year, which is hopeful, but you never know if you now use NIH. The earliest results is about 2021. So this takes a long, long time, actually, right? And the reason for that, again, is because it's not so much when we treat someone's hearing loss, we're going to improve their cognition. I mean, you guess you can make argument for some degree, but it's not we're looking for an improvement. We're looking for whether we can stem the decline. By definition, you've got to follow everyone for several years then. All right. So I'm going to move on to the last part of my talk right now. And this is sort of where I'm spending more and more of my time nowadays for various reasons. But it's getting at this fundamental idea that if 2/3 of older adults have a hearing loss, and we think that hearing loss is important now, we hope that treating hearing loss will make a difference. Well, I mean, what do we possibly do about this? Am I going to wait until 2021 to do something about it? You know, hopefully not, right? But importantly, from that perspective, though, you realize that we have some challenges ahead of our field, right? So I mentioned this before, the overall rate of hearing aid is about 15 and 20%, right? And this hasn't changed in decades, right? And a lot of people always want to assume right off the bat, and this is true, though, don't get me wrong, right, is that it's all about cost. It's just because we have to pay out of pocket for it, it's expensive, and because of that, that's why it's so low, right? That's true, but I'll tell you it's not the only reason. That's important, right? And the reason why I say that is because you can look for our data is about 15% of older adults have treat their hearing loss. If you go to the National Health System, England and Wales, right, and you look at the rate of use under a completely funded system, so bilateral digital hearing aids that are completely covered. There's about sort of maybe sometimes an 8 to 12 week wait sometimes, but don't get me wrong, but it's so completely free though, right? Their rate of use is marginally a little higher at best, right? So don't get me wrong, cost is important. I'm telling you, it's not the only thing. And what I mean by that is that I think there are sort of fundamentally 4 barriers to broader adoption or integration of hearing healthcare with sort of society right now. So one is clearly cost, right? But I'm telling you, it may not be the biggest one. I'll tell you, fundamentally a bigger issue is access. Accessibility of services, accessibility of technology. And what I mean by this is, as probably many of you realize right now, across the world, almost anywhere you go around the world right now, there is essentially only one model of hearing healthcare, right? And it's the gold standard. It's a clinic-based model of medical care where a patient comes to see an audiologist or possibly a dispenser for repeat visits for evaluation, needs assessment, counseling, sensory management, fitting, right? Back and forth, back and forth, back and forth. In the United States right now, FDA as well as state regulations limit direct access to obtaining a hearing aid, let's say over the counter per se, right? That's a fundamental issue right now too. So basically what this means then is for, let's say the average adult, is that if you're lucky, they start with a primary care provider and they say, I think I have a hearing loss, and primary care provider, if you're lucky, will say, well, you should get a hearing test. They'll refer you to an audiologist, right? So that is a referral right there. They see you guys and you get a hearing test. And as you know now, technically by FDA criteria, you need medical clearance though before you can fit a hearing aid. So then they may come see me about a month later. They get an appointment with me finally. I say, you have age-related hearing loss. You're fine. Go back to the audiologist, right? You go back to the audiologist, and the audiologist says, yeah, it's not funded though, and it's a bundled model, so it'll cost you about $4,000 to $5,000, and I can help you, right? Assuming they can pony that up, right? They pay that, and then you order the hearing aids, you fit, counsel, et cetera, et cetera. So what I'm trying to say is this whole process for the average American, of which 2/3 have hearing loss over 70, right? This whole process can take 5 to 6 months and cost $4,000 to $5,000, right? So to put that in perspective, right, that basically means then for the average American, getting quote unquote a pair of hearing aids can be their 3rd largest purchase in life after a house and a car, right? So there is something fundamentally wrong with this entire system to begin with, right? So the accessibility here over and above cost is a big, big issue, right? So I'll tell you that's just another issue, right? Another big one is probably many of you recognize in this room is fundamental issues of awareness, understanding, stigma, right? So I think many people assume in the medical community still even, because this research is still just evolving and new, right? Is that there's still understanding that hearing loss, it's just something you just get older, who cares, right? If something is natural as you get older, it's gotta be inconsequential then, right? And not many people realize now that we're establishing now these very, very clear links still between hearing loss and these broader outcomes. I think one big issue is we don't have the definitive clinical trial yet, right? And at the same time, there's poor awareness of what the impact of public health importance of hearing loss is. But fundamentally, there's a fundamental complete lack of understanding what even hearing healthcare is, right? I mean, how many people in this room think the average person on the street would know the difference between a hearing instrument specialist versus an audiologist, right? That's a huge failing of the field. If we can't distinguish what you guys do versus someone who's just technician trained with a correspondence course, that is a big, big issue. I mean, how many of you guys think even a primary care provider would know the difference? I mean, maybe a few, right? These are big, big issues. Over and above cost, these are big root issues that if we can't get over this, we've gone nowhere, right? And fundamentally, I'll say too that I think a 4th big barrier is fundamental issues of technology, design, and utility. And I'll say this from I'll get my soapbox, I can't help it. But I think there are a couple of things here, right? One is the way devices are designed right now is they are designed by the big 6 for you guys. They are not designed with the end user in mind because their customer in the end is not the end user, it's the audiologist vendors who buy the devices from them. What I'm trying to say by that, though, right, is because usually all people who can afford hearing aids are people who are more affluent to begin with. There's no incentive to make ones with bigger batteries or rechargeable batteries. Why? They don't sell, right? And finally, that's a perversion of the marketplace that since you guys are the consumers per se, they're not designed for the true end user. And that's a big, big issue, right? Along with that, that's just one thing I'll mention, though, and that's what if you go into a senior home, people always complain, why are the batteries so small? Why don't they make a rechargeable battery, right? This is why. They weren't designed for those people to begin with, right? Another big issue, I'll tell you this, and this gets more of a theoretical issue per se, but if we think about the situations when hearing really matters, right? In an auditorium, in a meeting room, TV, electronics, right? You realize that hearing aids always have fundamental limitations in these sort of larger rooms with reverberation, things like that. So if you want to hear well in these situations, we can, right? And what we rely on is a system that looks like this. Right? So yeah, you can get an FM receiver to a loop, or maybe there's a hearing induction loop. You can get a remote mic that goes to a streamer. I mean, so if this looks complex, it's because it is, right? So how many, on average, how difficult is it to explain this to an average patient who cares about these situations, explain that these are the solutions they need? It's incredibly complex, right? And yet these a lot of times are the most important situations for a lot of people, right? All right, so what I'm trying to get to is the end. I think there are not just one barrier. There are four, I would say, major barriers to sort of broader adoption of hearing healthcare, right? And importantly, I think it's one of those things, you just can't pull one lever and everything gets better, right? You just can't make hearing aids free without changing the system of care and awareness, understanding this thing, and all of a sudden expect everyone to care, right? You got to sort of pull all four levers at the same time to advance the field in tandem. I think that's the key thing, and that's why it makes it very, very hard. So on a more positive note, though, I think this is beginning to happen, right? And importantly, I think there are some very rapidly, I would say, future sort of current trends right now that are rapidly evolving, right? And probably one of the most important ones is actually, if you ask me, is that we're increasingly understanding and approaching hearing loss within this context of healthy aging public health. And what I mean by that is that hearing loss in and of itself, by itself, is not interesting. It's a usual process of aging, it's a hidden disability, yada, yada, yada. It's not that interesting. But if you understand hearing loss in the context of why it matters for the big important things, is when it becomes really, really interesting, right? And fortunately, I think this is beginning to be recognized at the national level, right? So one of the biggest ones, this just came out 3 weeks ago now, the White House Conference on Aging and the President's Council of Advisors on Science and Technology, the PCAST report. How many of you guys have heard of this? That's it? All right. So, all right. So we'll give this is something. If you have anything remotely to do with hearing loss in adults, this is something you have to know about. This is fundamentally at the national level about as top down as you can get. So basically, what happened in July of 2015, just 4 months ago now, is the White House had their conference. Who's heard of the Conference on Aging? A few of you guys. All right, that's not bad. All right. So the White House has a conference on aging about every decade, roughly on average. I think there's a fifth conference on aging they've had since the 1950s. And these are big deals. I mean, this is President Obama attends. This is a big conference on aging, which fundamentally address what are the issues, barriers to older Americans out there. What can we do to reduce costs, help them integrate, et cetera, right? These, for the last 50 years, we have them every decade, they lead to big things. They've led to the Social Security. They've led to Medicare. These have been major policy initiatives that have come directly from White House Conference on Aging, right? So one of the sub-themes that came out of the White House Conference on Aging this past July was around the theme of technology and aging. What can we do to harness technology to allow older adults to age in place, to increase their productivity, to increase their participation in society? It's a very, very broad topic for technology as a whole. Now, interestingly, what came out of that first sub-theme, though, was straight from the White House. The first topic that the White House wanted to see taken up was the issue of hearing loss and access to technology in older adults, right? So this is just 4 months ago, mind you, right? This got immediately tasked then to PCAST. So PCAST is the President's Council of Advisors on Science and Technology, basically President Obama's personal scientific council, with about 20 senior scientists from around the country in a variety of disciplines, but all very, very, very senior scientists who got tasked with looking at this just 3 months ago, saying the White House wants to take up this issue. What are the issues with access to technology for adults? So over the last 2.5 months, they've held a variety of open and closed meetings, have interviewed probably some people in this room, actually, right? And their report was officially adopted with their letter sent to President Obama 3 weeks ago, right? So there are 4 major recommendations. I won't touch on all of them here. I'm just going to highlight on a couple, and you can read the report yourself. I actually highly encourage you to read it. This is fundamentally a big, big deal, right? The first recommendation is this, is that the FDA should designate as a distinct category, quote unquote, basic hearing aids, non-surgical air conduction hearing aids, intended to address sort of basically mild to moderate hearing loss, and approve this class of hearing aids for direct over-the-counter sales, not subject to state regulations, right? So providing direct over-the-counter access to hearing technologies, right? This is fundamentally ground-shaking in terms of how the whole hearing industry now, even primary practices are developed right now, right? So this is one. The second one, there are three more. I won't go into all of them. The second one asked FDA to withdraw their guidance document on PSAP, so basically personal amplifiers, to make it less restrictive as well. And this, I won't get into this too much right now, though. But the big thing here, though, is that this report goes straight for administrative executive action, right? So there are certain things that the White House can do unilaterally without Congress, and things like this are one of them. That's why this report was basically commissioned by the White House, right? So it's still too early to say what's going to happen. Probably many of you have seen ADA, American Doctor of Audiology, came out with a position statement on this just yesterday, which, if any of you read, is incredibly supportive. They supported essentially all four of the recommendations. The American Academy of Otolaryngology came out with a position statement essentially supporting all four as well. I think AAA hasn't done anything yet. I'm not sure ASHA has either. But many, many people are weighing in very, very quickly with this. And what we've seen so far is only people who are coming out frankly against it are the Hearing Industries Association of America, which is very, very threatening to their business model, obviously. Right? All right. So this is big, right? In parallel to this, I would say almost equally as big, or maybe even bigger in many ways, is fundamental what's going on at the Institute of Medicine right now. So probably many of you have heard of Institute of Medicine. Institute of Medicine is a independent body from the government, but it's often charged by Congress or the government with producing position statements, consensus summaries, recommendations for topics ranging from vaccines to national security issues, if that's more the National Academy of Sciences, things like that. So what's happened with Institute of Medicine now over the last 2 years is they've also gotten tremendously interested in this topic of hearing loss, and in particular hearing loss and things like healthy aging, mainly because it's seen now as a potentially modifiable risk factor for big, big important things. So to start it last year, January 2014, they hosted a formal 2-day workshop to explore all the issues related to hearing loss and healthy aging, inviting a variety of stakeholders, and they published a report on that just last year. Non-binding report, basically just a summary statement about the whole issue. But immediately what that was done is that's been taken up by various funding agencies now to immediately fund now for the IOM to do a formal consensus study. So what a consensus study is, it takes place over about a year. We have about a series of meetings over about the last year. We had the last meeting just yesterday, actually. And what we're charged now with doing, what the IOM Consensus Committee is charged with now, is coming out with, by next year, a formal set of consensus recommendations now to all of government about what needs to be done to broaden accessibility and affordability, of which something like the PCAPs, which narrowly focus only on access to devices and industry, is just one component of what the broader IOM report will do. So this report is sort of very much sort of complementary, probably what PCAST has been trying to do as well, and this report is due out next year, right? So these are two major, that if you're anywhere in the field that you're addressing hearing loss in adults, that these are things you have to read. I mean, this is not a bottom-up process. This is about as top-down as you get for major, major changes that's going to affect all of us in this room and hopefully affect society as well, right? All right, so I think that's on a very, very positive. That's what's happening there. I think a second big, I wouldn't say future trend, a current trend, I should change the slide, is fundamental innovations in hearing healthcare technology. And what I mean here is broadly the issue of accessible services and affordable technology, right? And probably all of us in the room here have heard of PSAPs. Who's heard of PSAPs? Good, almost all of us, right? So PSAPs, personal sound amplifiers, non-regulated by the FDA, some over-the-counter. You can't claim to treat hearing loss. You can't claim to help impaired hearing. But as maybe some of you realize, though, some of these can be completely indistinguishable down to the microcircuitry level than a hearing aid. I mean, you could take an Oticon Agile Pro, call it a hearing aid, and say it's hearing loss, and it's a hearing aid. Just strip that labeling off and just say, it just, you know, it's a boost hearing and for people with normal hearing, right? And you can sell it as a PSAP. There's no magic there, right? The fundamental issue there is, as you understand about PSAPs, so PSAPs also encompass things like hunter's ears. You go into the woods and you want to hear the deer, you put this thing. Those it's just a broad category, right? So what that functionally means then is that if you're trying to use, quote unquote, a PSAP because you actually have impaired hearing, about 98% of them are just junk. I mean, those are ones you see at the CVS store. Those are ones you see in the back of magazines that say $39 miracle. We've all seen this before. I'll say 99% of those are just garbage, complete garbage, right? But a few of them are really, really good, right? In particular, those are the ones which usually, I'll tell you, were designed by people who knew what they're doing. So the costs here are dramatically lower. Maybe you cut out a lot of the middlemen in terms of how these devices can be marketed and sold, right? One device I'll just mention, I have no personal affiliation with the company at all. I do know these people, though, because I actually use a device in my research, is a company called Sound World Solutions. The reason why this company is interesting, it was founded by two people. Actually, have any of you heard of Sound World Solutions? All right, good. So Sound World Solutions was founded by two people. This guy here is called David Green. So David Green won the MacArthur Genius Grant, or MacArthur Fellowship about 5 years ago for being a social entrepreneur. What David has done, who I consider a good friend, about 15 years ago after getting his public health degree, he went to India. And in India, the leading cause of preventable blindness is cataracts, right? Actually, same around the whole world. And back then, if you want to get intraocular lens replacement, cataract surgery, the surgery could be relatively cheap because essentially labor is cheap per se, right? But the actual lens was about $400, right? And that is very cost prohibitive for a developing nation, right? So what would happen every now and then is Johnson & Johnson may donate some device or donate some lenses to India, it'd be all good, and everyone shakes your hand, says hallelujah, but it wasn't sustainable, right? So what David Green went in, he's like, well, why is a little piece of plastic $400? I mean, it doesn't make sense. So back then, he found his own company called Aura Labs, and without violating any patents, they started manufacturing their own intraocular lenses, and they started selling them for $3. To this day, I think they are still the third largest manufacturer around the world now of intraocular lenses, right? About 5 years after that. So by the way, the reasons they want to do that is because David's a really, really bright guy. He understands the whole supply chain side of things. He understands where everybody's getting their cut, where they probably shouldn't be getting cut, and why it's so inefficient, right? So about 5 years after that, Aura Labs took on the issue of surgical sutures. Sounds so esoteric, right? But surgical sutures also made by Johnson & Johnson were usually, I think, about $25 a box. Right? And he was like, well, why is a piece of string $25 for like essentially a pack, basically? He's like, that's ridiculous. So Aura Labs, David Green hired on a person who used to have a small suture company in Germany, and they started manufacturing sutures for Aura Labs, and they brought the cost down to $2. Now, what's interesting here, though, is that around this time period, they bid for essentially this $1 million contract from the government, Indian government, to provide surgical sutures, and they actually won the contract, as you can imagine, right? But then they promptly got sued by Johnson & Johnson for a variety of reasons, right? And that lawsuit actually went all the way to the Indian Supreme Court, and they eventually won the lawsuit, but by then Johnson & Johnson had dropped their price to $2, right? So David Green himself has a mild to moderate hearing loss, and you can imagine the person he is. He's like, well, why are hearing aids so bloody expensive, right? So about 6 years ago now, he paired up with a guy called Stavros Baseas. Anyone know the name? Yeah, so Stavros, as Harvey knows, Stavros Baseas used to be the chief technological engineer for GN Resound, right? So he knows what he's doing, in other words. So they paired up, and they found a company called Sound World Solutions nowadays, which makes quote-unquote PSAPs, per se, right? Which are pretty good, right? And the way they do this, their device is a little unique, though, because they do actually in situ fitting and verification, per se. And what I mean by that, it's not our classic real ear verification, but what happens is you don't just plug in your auditory thresholds or pick how much gain you want, right? It pairs with your phone, right? It plays tones at different frequencies. You report whether or not you can hear it based on your iPhone or your smartphone, right? So through the same coupler, it's like they report whether you can hear it. And based on your responses in situ, it programs your amplification based on it, right? So basically, you can imagine as close as you can get to like a verified fit, per se, in a self-do method, right? But that's what they do, though, right? Now, importantly, they're not the only company that's really, really good. Another company, which is much more of looks more like a PSAP, not like a real hearing aid. Have you ever heard of SoundHawk? So SoundHawk, funded by Ronnie Perkins' group, formerly several Resound execs as well. So basically, it comes with a mic you wear in your ear, the amplifier you wear in your ear, which looks like more like a Bluetooth. They want to look like that. It also comes with a remote mic as well, right? And you program with your phone. I've actually used it. It actually works really, really nicely. It's quite good, actually. At the same time, what's interesting is you have companies like this. How many of you have heard of Bragi? Probably no one, right? Yeah. So the reason for this is because Bragi is not developing a device, quote unquote, for hearing loss. Bragi last year at the Consumer Electronics Show in Las Vegas, and there's more and more of these sort of devices at the CES. They won the CES Innovation Award, and what they have is a small startup company in Germany. You can actually go to the website, you can order it now. I think it's being delivered this fall. It's a little pair of neon earbuds, right? And these things are wireless. They have headphones, they have MP3 player, microphone, Bluetooth headset. It tracks your distance and your heart rate, right? And oh yeah, it could also just not only do simple pass-through, it could also amplify sounds, right? So the fundamental question here then is that a hearing aid or is that just a consumer electronic? And I think what's rapidly emerging, as probably many of us realize, and this is not unique to our fields, this is across essentially all of medicine now, is that there's increasing convergence between what is a consumer electronic versus what is a medical device. And this blurring is happening incredibly quickly, right? All right, so at the end though, and Nick Reed is one of my postdocs in the room, actually presented a post on this a couple days ago, is, well, what objective evidence do we have that some of these quote-unquote PSAPs, are they good or are they bad? How do we do it, all right? So what Nick's been doing over the last few months is he's been doing sort of electroacoustic real ear analyses of certain of these devices. And as you can imagine, what you'll probably find is that some are really lousy and some are good. So for example, this is basically, this is the Sound World Solutions device. So the black line here is what will be prescriptive NAL, NL2 targets. The gray hashed area is basically what will be within 10 decibels a hitting target per se. The red, purple, and blue are basically different presentation levels of stimuli, right? So we can see something with the CS50, it can actually pretty decently hit what we consider to be target, right? The SoundHawk device, sort of same thing. And I'll tell you, this is not coincidental. These people, when they design these devices, since they're designed by usually former sound engineers, they did this on purpose, right? So that's why they're actually not bad. But they have other devices, I think it's called something called the Tweak, which is just, it's boomy in the basis, so it sounds loud, but it's actually terrible, right? So I think what all comes, you can't just broadly say, oh, PSAPs are all bad, PSAPs are all good. There's not. There's a tremendous amount of heterogeneity in terms of how they're designed, the pedigree of those devices, and what they're designed for, and who designed them, right? But these type of basic questions, analyses, studies, looking at these things are not really being done. And yet it's such a basic question, right? All right. So that's just one issue. Is I think there's fundamentally a innovation that's going on very quickly with more affordable technology, whether you call it an over-the-counter hearing aid or a PSAP, what have you. But this is rapidly emerging. So outside the big six, rapidly emerging, very, very affordable technology. Probably many of you guys heard. How many of you guys heard of the ADA Intracon venture? I'm sorry, the what? The ADA and Intracon venture, the ear venture. Oh man. All right, so I should know more about this than you guys, but listen, so what ADA paired with Intracon now is if you're an ADA member, Intracon will manufacture basically a pretty basic digital hearing aid and sell it essentially for $150 wholesale cost to the audiologist, right? So what's happening really rapidly outside the traditional big six is the rapid emergence of innovations for more affordable technologies, right? All right. Beyond that, though, technology is great. Technology is one piece of the pie. Technology can help many people, but maybe not all people. What about services, right? And what I mean by this is that, let's face it, there are 11,858 audiologists in the whole country, I think, right now. I think it's the latest number I heard, right? So there are about 12,000 audiologists in the whole country, maybe about 6,000 dispensers. There are not enough people, quite simply, if you're going to really serve everyone who possibly could benefit. There's never will be, it just won't be, right? So what else do we do? So what's emerged now from a researcher called Nicole Moroney at the University of Arizona, as well as for my group now, is beginning to test now the idea of using community healthcare workers to provide primary front-level care for some basic hearing rehabilitation, right? So community healthcare workers have long been used in other sort of very, very common chronic conditions of older adults, hypertension management, diabetes management, even depression management. So basically train a lay health person to basically provide a very specific set of service in the community, in that person's home, like literally going out to where they normally live, right? So not bring people in the clinic, and train them with a very specific set of skills, but under supervision of a broader care team, a clinical team, right? So what's been happening right now is one of my previous postdocs called Carrie Neiman and I, we founded a nonprofit. It's called Access Hears, which stands for Hearing Care Equality Through Accessible Research and Solutions, where we develop a CHW model, which we begin to disseminate and test now through various nonprofit as well as NIH grants. But what Carrie did a couple years ago maybe 3 years ago now, is she began manualizing the HEARS intervention, an intervention designed to be delivered by a lay health person in the community, which would do three things. It would provide basic hearing loss screening with a portable audiometer on basically essentially an iPhone now, provide essentially immediate provision of a self-fit amplification device, namely a PSAP, right? You can't do a hearing aid, it has to be called a PSAP. as well as helping them learn how to use it, right? And then immediately providing sort of expectation management, communication strategies to that person, as well as his or her communication partner, right? So essentially a 2-hour intervention designed to be given by a CHW at an average cost of about $120. So $80 for the device when we buy it wholesale, and $20 per hour for the CHW's time, right? So far, we've piloted this now in 3 different populations, something called Weinberg Senior Living, which is basically senior housing towers throughout Baltimore City, which are basically affordable housing for low to moderate income older adults. Sarah Mamo, my other postdoc, has been doing this now specifically in people with cognitive impairment, with dementia in group homes, for instance. So basically, people with existing dementia, can we lessen some of their communicative burden and hopefully help some of their neuropsychiatric symptoms? Not reversing dementia, obviously, but can we help reduce some neuropsychiatric symptoms of agitation, things like that? And finally, Janet Choi, another of my pre-doctoral students, has been developing this and has developed this and has implemented a Korean version for basically, there's a large Korean American population in Baltimore, many of whom are first generation who don't speak anything besides Korean for the most part, who have no access now. As you know, probably always realize there's very little diversity in audiologists, right? But bringing some type of more community-based solution to them as well. And looking at some short-term outcomes over 3 to 6 months, looking at social engagement, communication, things like that. And where are we right now is from 2013 until now, intervention development. We've been doing pilot studies for the last couple of years. And where we're rapidly moving toward now is through the nonprofit, we're doing dissemination with various state agencies, as well as even some international ones are interested in licensing what we're doing, as well as with NIH grant, do more official sort of testing and refinement. So that's all ongoing right now. Right? And to give you an idea what this looks like, this is just sort of the draft materials are still being refined. But I mean, it's very, very conceptual. There are no numbers, there are no audiograms, right? We explain, normal hearing, signal that goes in is what goes to your brain, so it's very clear. When you have some hearing loss, it gets a little fuzzier, right? So no numbers here, no audiograms, people don't really care, right? But you conceptually explain what hearing loss is. We go over some communication tips and tricks, right? If someone didn't understand you, repeat it once. If that does not work, reword it. So aim for a communication partner, right? Saying, what did you think of the meal? What did you think of the meal? Tell me about the food. So very, very basic concepts around oral rehabilitation and communication repair strategies, right? And finally, with the devices, there's a first generation CS50 device we're using. Now we've moved on to the next generation. But just really going over basic stuff. I mean, it's a big rechargeable battery, by the way, which makes it very nice. How you connect the battery, having a checklist of making sure they know how to use the device properly, right? So again, this all takes about 2 hours for this intervention, right? Now, importantly, this is small, but I thought I'd like to read it though. So I think quantitative today is all good, and that's wonderful, right? Now, I'm not going to bother showing you that, right? But I could, but not. I think what's more interesting a lot of times though is some of the qualitative data we've been collecting. So this is a project that Sarah Mamo's been doing where she adapted HEARS for implementation in the memory clinic at Johns Hopkins, right? So basically, patients with existing dementia implementing when they come to clinic for other clinical visits, immediately intervening with them as well as him or her and his or her caregiver, right? So this is just, we track some quantitative data on neuropsychiatric symptoms, other things like that. But we also ask every week, we ask them to keep a little guidebook and just log what they're noticing. Right, so this is the feedback from the son-in-law of a 91-year-old woman with an MMSE of 70. So basically, she had dementia. And what he reported at week 1, read out loud because I know it's hard to read, and his handwriting's a little messy too. This week, there was trouble adjusting the volume. Different TV stations had different levels of volumes. People came into a room with different ways of expressing themselves. She would holler that the device was too loud. Right? That's week 1. Week 2, the stopped right away. Her asking to repeat a statement has almost disappeared. The speed of conversation has quickly picked up. She helped me to adjust the hearing device to make things more comfortable. Right? That's week 2. Week 3, she began telling her historical stories more accurately. She asked me questions in smoother sentences. Her patience was extended. There were less hurry-ups. Right? Week 4, she seemed to be less interested in having her way and imparting restrictions on the second party when she did not get her way. Right? And finally, week 5, which was the end of her follow-up period, he wrote, her willingness to make decisions is stronger. Such decisions have made more sense. Note, the dementia is still there, but it seems to take more of a backseat in her life. Right? So this is a $120 intervention delivered at the point of care, which is, you asked me, incredibly low-hanging fruit for making a difference before they even get in to see an audiologist and fitting a $4,000 device. I mean, this is the stuff where there's so much low-hanging fruit here where our field, if we think about a problem in the big picture, could make a huge difference, yet I feel that very few people are moving in this direction yet, right? All right. So to this end, getting closer to the end of my time, right? I think right now in the U.S. around the world, there is one gold standard model of hearing healthcare, right? Which is, and as it should be, this will be the gold standard, audiologist directed care, clinic-based care, right? Takes 3 to 3 months. It takes a lot of time. It takes a lot of expertise, and it takes a lot of expense. And there's nothing in between, right? So I think what's rapidly emerging now is that there needs to be diversification in terms of delivery models, where you can imagine at the lowest level would be the wide availability, hopefully based on the PCAST report, of over-the-counter technologies, some of which, because we're going to be regulated, will be very, very good, right? And that may be enough for some people, right? The next level, some people, listen, they still won't be able to figure out the device themselves, right? They need a little help, right? They can't, they're not going to make the commitment to come back and forth, and they don't want that level of service, right? And I think there's a role, clearly a role there for CHWs, community healthcare workers, to provide an initial frontline level of care. Then above that, hearing instrument specialists, technicians who are trained to precisely fit a device, but don't necessarily do the whole oral rehabilitation and counseling, things like that, right? So I think this is what needs to happen, right? If you look at almost any other chronic medical condition, whatever you have, these things happen. There's evolution, there's a progression, there's different levels of care. And yet here in healthcare right now, there isn't. And that's a big, big problem, right? And following what I think happened here, and these are just two of my postdoctoral audiology work with me right now, is what I've been constantly encouraging to think about is how the audiologist can be essentially the leader of this team, right? Because it shouldn't be directed by me. It shouldn't be directed by a hearing specialist. It needs to be directed from you guys. I mean, so we should be practicing the scope, at the top of your scope of practice, in other words, to do this, right? And I think this will hopefully evolve over time. All right, so this is just, that's one big thing, right? A second one, which I won't go on too much about, but I do feel strong about, so I just had to slip it in here, but I think it is important, is the issue of open wireless standards. And usually the response I get here is like, what are you talking about, right? But this is important though, right? So if we look at the fundamental limitation of all hearing aids, right? I think probably many of us agree it's how to increase signal-noise ratio. Right? The speaker is here, and I'm all the way back, and there's no amplification system. How do I boost the signal-noise ratio, right? Hearing aids with a microphone at ear level can only do so much, right? So clearly the way to really do it and how it's been approached is typically, as industries approach it, has been a lot of post-microphone algorithmic processing of sound, beamformers and things like that, right? I mean, you get a boost of what? Harvey could tell you more than I could, maybe like +1, +2, maybe +3 gain in SNR, right? Boost in SNR. But it's not like, it's not sort of hit out of the ballpark sort of thing, right? And I think probably many of us would probably agree is that we are probably rapidly reaching the point where we won't be able to boost anymore, just purely based on the size of devices and the battery power that's available. With a supercomputer, we probably could, but not in real time with a little half-ounce device with a little miniature little battery, right? And yet, some of the most promising things are if you can go pre-microphone, right? If you can move that microphone closer to the speaker, I mean, your boost in SNR is what, 20, 30 minimally? I mean, they were exponential, I guess. I mean, as much as you wanted to, right? And the way we've gone about it now is, hearing loops, when they're installed, they work great, right? Also proprietary wireless systems, depending on which manufacturer you use. They come with different types of wireless mics. Some are 2.4 gigahertz, some are 900 megahertz. I mean, it runs a whole gamut, as you all know, right? And fortunately then, unfortunately I should say, what it looks like is this, is that every single manufacturer has a different device. They're not cross-compatible. There's some rooms have FM systems, some have loop systems, some infrared. It's just a mess, right? We all know it's a mess, right? So why can't it be a system like this? Why can't there be a universal frequency for near-field sound transmission, which is approaching a little bit with Bluetooth LE, as you guys know, with the latest resound and Stark hearings, there is some Bluetooth LE or Bluetooth Smart being integrated into it, but still not universal, right? But it still only is fundamentally used for near field, right? So it functions on a handshake protocol. You can't broadcast. What about far field? So rather than having to have a loop installed, what if you go one common wireless band that sent out a signal with any compatible device? You hit a button, you pick it up. Even if you have normal hearing from the background, you're going to hear better, right? So you can't basically do it with Bluetooth right now. But with something called Wi-Fi Direct, you possibly could. So Wi-Fi Direct allows peer-to-peer, right? So you can broadcast, right? And there's thoughts now that we need to develop a sub-protocol now for sound transmission, but I'm pretty sure this impetus will not be coming from the big six. This is going to be coming from the consumer electronics side, right? And yet you can imagine if this evolved, universal frequencies, universal transfer, this changes everything, right? Because when you convince me as a 39-year-old person with essentially normal hearing, I think, right, that I want to wear a device like this, right? You've won the game, right? And to be honest, actually, caveat, I've actually ordered that Bragi device before I showed you, right? The little one, because I actually go running a lot, but I haven't got them yet. But if that also had like some kind of wireless band, you pick whatever, I would love it, right? Because I could sit in the back of the theater and hear everything. I mean, that's where it's a big game changer. But this stuff usually probably come from the consumer electronics side. And I think that's why with the PCAST report, with the C8, the Consumer Electronics Association is doing, I think this is what's going to emerge. I don't know how long it's going to take, though, but I think this is almost inevitable in terms of how we approach it, right? All right, the last thing I'll mention here is clearly, as you all know, this is essentially a travesty. The 1965 CMS Medicare Act sees all of you guys as diagnosticians and diagnosticians only. I mean, what gives, right? So there clearly needs to be coverage of the services you guys provide beyond diagnostic services. And I mean, these are all things that are being discussed at the higher level with the Institute of Medicine. I mean, they're all looking at these issues, things like that. So whether it will change, I don't know. But this is where everyone's sort of talking about it. But I think what could happen here rapidly, very, very quickly, though, is that there is going to have to be a fundamental process of unbundling. You can't bundle things together. It does not make sense, right? Where conceive like it's even a model in the future where there's coverage for audiologic services somehow through insurance companies, but there's actually no coverage for devices. And to be honest, I don't think it's a bad thing. I mean, the pace of device nowadays in terms of, especially once you get the consumer electronics industry involved in things like this, you're dropping to less than $100 for devices nowadays. Why should they be covered? I mean, if anything, make people pay for it, make them value a little more, but your services will never be that way. Your service can never be commoditized, right? So the fact that still most audiologists and hearing most audiologists still bundle, it's absolutely bizarre to me. It just doesn't make any sense with how the field's heading, especially with this PCAST report coming. I think everyone's going to have to change to some degree. All right, so this is my last slide. And the reason why I show this slide at the very end is because I think no matter what you do in this room, whether you're a researcher, a clinician, or a policymaker, what have you, it always comes down to the people we care about and the people we want to help, right? So this is actually my 92-year-old grandmother, who for the last 20, 30 years has had a mild to moderate hearing loss, right? And she was hearing aids for the last 25 years too, at least. And this is about 3 years ago now. I'm sitting down with her at lunch, and she's asked me how work's going. It's all in Chinese. And I'm going on about, oh, this is going fine, and I'm studying this research and these 3 questions, et cetera, and I go on and on and on. And after about 5 minutes, she's looking just a little more like just a little disconcerted, and she stops me, and she's like, are you telling me that I'm going to develop dementia, right? Yeah, and she was not happy, actually, about this, right? So, I paused, and I said, Grandma, and I was like, no, of course not. For example, you have high blood pressure, and because of that, you're 3 more risk of having a heart attack and a stroke, right? Which wasn't probably the best way to explain it, but she knew what I meant, though, right? Because on a population-based level, if you have high blood pressure, you're more likely to have a heart attack and a stroke. I said, with hearing loss, it's the same way. At a population-based epidemiologic level, we're understanding that hearing loss likely increases our risk for dementia and things like that. But it's on a population-based level. There's obviously a tremendous amount of individual heterogeneity, right? And I said, with hearing loss, we're understanding it's sort of this same pattern. Now, obviously, what we're missing here, though, is a definitive clinical trial, so whether treating hearing loss makes a difference. Now, the reason why I like mentioning this example at the very end is that there aren't internists in the room, are there? Geriatricians or anything like that, or primary care doctors? Okay. So the reason why I mention this example, though, is because we take it for granted now as a society that high blood pressure, if you're a 65-year-old person, you have high blood pressure, you treat it. Right? It's almost like God-given. It's just a done deal. Of course you treat it, right? Yet the amazing thing about it, if you ask any primary care physician who's over 50 years old, and you ask them just 25 years ago in the early 1990s, if you had isolated systolic hypertension, that higher number, if you had isolated systolic hypertension, it was less than 140 plus your age, that was a rule of thumb. If it was less than 140 plus your age, not treated, right? So you could be a 70-year-old man, and if your blood pressure was, let's say, 200 over 70, not treated. Because the attitude back then, understanding back then, was that hypertension is very much often a usual process of aging. Your arteries get a little stiffer over time, your blood pressure goes up, you get more blood to your brain. It's a good thing, right? So that was the accepted thinking for literally decades, until 1992 or 1993, something called the SHEP study came out, the Systolic Hypertension Elderly Program trial came out. A definitive randomized clinical trial, took several thousand adults, randomized to a diuretic therapy, I believe, versus no therapy, and dramatically dropped rates of heart attacks and strokes, right? And literally, I won't say overnight, but over a year period, that changed the entire worldwide management of hypertension. And many people would probably even say, you're seeing the sequela of that nowadays with possibly an absolute lower risk of dementia because of the attention now paid to midlife vascular disease back then, right? So I think there are a lot of parallels between that and hearing loss. Hearing loss, like hypertension, can be very much a usual process of aging, but what we're increasingly understanding, though, is that it might not be without consequence. But what we're still missing, though, is what is the definitive evidence, though, that if you treat it, how much of a difference can you possibly make? So I'll finish up there, and I think we still have some time for questions, and just thank you for everyone's attention.
Hi, my name is Fatima. That was a great talk. I have two questions, actually. The first one is, what is the best practice for including or excluding people with dementia who also have hearing loss when we do research related to communication? Because it seems like, I was wondering like whether we should exclude those who we should include those who only wear hearing aids or some kind of hearing amplification, or we can actually include those with mild, moderate hearing loss who are not being treated.
So Fatima, I couldn't quite hear, the microphone's all bad, but yeah, you're asking what is the best practice for addressing hearing loss in people with dementia? Is that,
no, for including or excluding them from research. So for inclusion, exclusion criteria?
Yeah, I think that's a tough one. I think it all depends on the scientific question you're trying to answer, right? So for example, for our clinical trial, for instance, there's going to be no dementia, even cognitive impairment, because the question there is, can hearing loss delay cognitive decline? So I think it all comes down to what the scientific question is. Does that make sense? I mean, I guess maybe one question is if you have intervention, can it help reduce neuropsychiatric symptoms for, let's say, some type of behavioral therapy or something like that? I would hope you wouldn't exclude people with hearing loss and dementia. Wouldn't it make sense? I'm not sure if I'm getting what you're asking, but I think it all depends on the scientific question you want to ask for how you define your inclusion-exclusion criteria.
I mean, like it's a guide to like where we need to find more information about that. Okay.
Yeah.
All right. So secondly, like with your Achieve project, you were saying that one group is getting that best treatment for hearing aid, and the other one is getting successful aging, which might not be related to fitting hearing aids and so forth, right? So in the end, like after you after you collect all the data, will you be like giving them, will both groups receive?
Yeah, no, I think right now as currently conceived, the trial is at the end of the study. If you want to receive the other intervention, whether it's successful aging, healthy aging counseling, and or the treatment of hearing loss, you can receive it at the end of the trial.
So it depends on the participant themselves?
Yeah, exactly.
All right, thank you.
Thanks.
Hi, again, my name's Aaron Roman. I have a question actually regarding, I have a question actually regarding the bit you talked about changes in brain density and, neural changes. So you said in your study you looked at changes to superior, inferior, medial temporal gyri. Do you notice any larger scale changes, such as, there's associations with the prefrontal cortex and premotor cortex. Do you see changes in that as well?
So great question. So we didn't. So don't forget though, these type of neuroimaging analysis we're doing purely are structural measures of volumetric measures. So we didn't actually. Not to say they're not there, just with 126 people, it's relatively small, though that's big edge for neuroimaging study. We didn't see any change in prefrontal cortex. I mean, in terms of structural, right? But one thing we are moving toward now, though, is beginning to look at diffusion tensor imaging, so tractography in the brain, whether the tracks are changed. That's going to be a little iffier, that's hard. The bigger thing we're looking at, more importantly now, is we're beginning to look at something called default mode network in terms of functional MRI. So it looks at patterns of how the brain, in the resting state, how it works, and whether we see changes there, right? Because, I mean, based on the functional neuroimaging in terms of patterns activation, we see that on either fMRI or something called high-density EEG. Anu Sharma is doing that work actually in Colorado. But we will we'll soon begin studying that, looking at resting state fMRI, which looks at patterns of activation. So I think there are many ways to sort of get at the brain, of which structure is just one of them. And we haven't looked at cortical thickness either. So but we didn't see, at least on that initial set of analysis. Yeah.
Hi, I'm Julie Delmaso. I have a question about the cognitive assessments that you mentioned that they don't need the verbal audibility to complete the tasks, but how are the participants given the instructions? Wouldn't those still have to come from a verbal nature?
Great question. Yeah, so this comes up all the time. And I mean, you can imagine 2/3 older adults have hearing loss. So I mean, how do you standardize so you're not limiting these compounds? I'll tell you, for a study like ERIC, the way to do it is instructions are printed written and verbally, right? And so that's a big thing right there. And also, again, for the most part, these instructions are being given face-to-face, quiet room, so it's obvious. But usually they're written instructions as well, though.
Thank
Yeah,
you.
great question.
Barbara Cohn, our VP for Academic Affairs and Audiology.
Thanks, Frank. I have a comment first and then a question. And my first comment is about the gold standard for treatment, which you defined as audiologists, $3,000 or $4,000 hearing aids. I'd just like to say that I think that it is a result of the FDA regulations and some of the decisions made by the medical community over the last 30 years. We have been hamstrung by that to only provide that kind of care. So I think with this call for a decrease in regulation, we as audiologists can come up with better models. But we have been hamstrung by these regulations.
No, I completely agree.
But I do have a question for you. I'm so glad that you brought up the example of cardiovascular intervention that is now the norm. And that is, with a complex condition like cardiovascular disease or even diabetes, would you recommend over-the-counter treatment for that? Because it seems to me that hearing loss is also a very complex disease or condition, and we're recommending over-the-counter treatments now. Would you recommend over-the-counter treatments for other healthcare conditions that do impact dementia, like cardiovascular disease or dementia?
I mean, a lot of the cardiovascular ones, I mean, yes, medicines are great, but even beyond that, though, exercise, things like that are, I guess, over the counter as far as you can say it. I mean, I think it all depends on the system you're talking about. I mean, analogy that PCAST used was the issue of readers, right, for vision and things like that. You can get prescription spectacles or you can get magnifying spectacles.
Yes, but would you manage cardiovascular disease completely in the hands of a person who could buy an over-the-counter medication and not have the opportunity to consult with a qualified healthcare provider? Okay.
No.
Yeah, so
Yeah.
I think that we have to temper some of what we're saying about over-the-counter treatments with the realization this is a complex health condition and there will be a considerable need for a person with such a complex condition to be able to be seen by an appropriate healthcare provider, which I think is the audiologist.
I'll qualify that, though. It can be complex. It doesn't always have to be complex, right? So I think the key thing there is that there are multiple different components of what we call hearing health. There's screening, diagnosis, counseling, training use of device, ALDs, and there are all these different components of it, right? And I would argue for any given person, they may only need one or two, or they may need all. But I think it varies from individual to individual. And yet we don't give that option right now, more importantly. Yeah.
I had a question, and that concerns, will this work for kids as well as adults?
Ooh, no. No, I think that's a whole different ball of wax. No, completely. I mean, the PCAST report is only written for adults, actually older adults even. IOM report, we're limiting purely to adults too. Pediatric hearing loss is a whole nother beast where that has to be medically evaluated. That's completely different though. Yeah, no, I agree. Yeah.
And of course, there are many of us that are worried that parents in the future will just slap whatever they get at CVS or Walgreens onto their kids. And do you have any sense of how these governmental and the IOM agencies are going to manage that risk? Just how to manage that risk?
Can't really probably comment at this point, but it's something that's come up, obviously, that topic, yeah. But this, let me say, that's not unique to hearing devices. You can apply it almost to any type of over-the-counter where you could do the same thing. Let's put it that way, right? Yeah.
My name's Jan Moore, and I'm from Nebraska. And I'm interested in this model looking at farmers and actually even starting with teenage children who are exposed to noise, and so they are developing noise-induced hearing loss over their lifespan, and seeing if maybe these cognitive defects or deficits start earlier in patients like that. Do you think that's something interesting to pursue?
No, I think it's a great question. I mean, you know, all these epidemiologic studies, the data have been done, you know, brought people to 60s, 70s, 80s. Probably the vast majority of age-related loss began in the 40s, 50s. But none of these studies have enough power to distinguish an early onset. I mean, we exclude early. I mean, pediatric congenital onset, obviously. But in terms of when onset began, I think it's a great question. It's just hard to study because you need a lot of data on a long-term cohort of people. So it's tough, though. Yeah.
Okay, I'm Evie Whitting, and I am a North Carolina Central graduate student. Going off of that question, do you know if there are any studies that have been done studying early onset hearing loss and then later developing or cognitive decline?
So I don't. And I think, let's take it to extreme. I mean, let's say children who are born congenitally deaf who grew up in deaf culture, right? I would argue all these pathways we talk about, cognitive load, brain structural changes, social isolation, don't really apply anymore. I think hearing loss, the way the brain adapts to hearing loss when you're born with it, is really different than what happens for the rest of us who are all hearing and develop it later in life. So I think it's very, very different. But as far as I know, no one's really studied it. It's just hard to come with a study that follows that many people, though. But I think it's very, very different. Congenital onset hearing loss versus adult onset hearing loss. Yeah.
Hello, Harvey Dillon. Just a comment on the comment that came up earlier about there not being any evidence about early intervention in kids, just since kids have come up twice. There actually is. In Australia, we had the opportunity when we had some states had newborn screening and others didn't, but no matter what age they got found, they all got treated the same way by the national organisation. So we jumped in there and started a longitudinal study. Those kids are now 9 to 12 years old. We recruited them when they were babies or up to age 2. And there's a huge difference between the ones who got the early intervention and the ones who didn't. I just wanted to correct that record.
Is there a citation you could give us for that?
Yeah, there's a special issue of the International Journal of Audiology of earlier this year that's got a bunch of papers. That's at age 3 data, and the age 5 data we're working on at the moment. So look for Teresa Ching is the person leading the study.
Yes, Nancy.
I was interested over a 40-year period or whatever, these increases with age of hearing loss have remained about the same. But now we have a generation of people who grew up on rock music and iPods in their ears and so forth. And they're now becoming the aging group. Do you have any hint that may change the profile of hearing loss increases?
I don't. I mean, I don't see any data to show that. I mean, the most theoretical thing I would go out on a limb and say, though, is more like, so for like Charlie Lieberman's work and Sharon Kujawa at Harvard, basically showing that with a lot of noise exposure, you can get actually glutamate excitotoxicity, where you actually preserve relatively normal thresholds, but you actually lose the spiral ganglia, so you hear far worse than your thresholds look, right? That's a big picture there. In terms of how that would extend to people who have had a long history of noise exposure from rock and roll, iPods, I mean, I don't think anyone knows. I don't, yeah.
I'm Rosemary McKnight from CU Boulder. Do you think there'll be any recommendations forthcoming about a hearing screening program? At what age to start offering routine screenings as part of primary health care?
I don't know. I honestly don't. I mean, the USPSTF, I mean, the United States Preventive Services Task Force, they came out with their report 3 years ago now on hearing screening for adults over 50, where they do a comprehensive review of the literature, et cetera, and they found no evidence to suggest it to do hearing screening. Not because they shouldn't do it, it's just that there was no evidence, right? So I don't see a new report changing anything because there have been no new studies since then, unfortunately, right? Yeah.
Hi, I'm Nancy Nelson from Indiana University, and I just have a comment about, you just referenced Sharon Kujawa's work, and just thinking about this public health model and how it might work and how consumers might get more direct access either through telepractice or through telephone hearing tests or a variety of ways that they can be tested. That work makes me think as an audiologist that the pure tone audiogram probably isn't going to continue to be the end all and be all. And so I would just caution that as we move forward with these really large scale kinds of initiatives, that we think carefully about adding some additional kinds of testing. Maybe speech and noise testing might be the easiest to implement.
I'm Winnie Chung, and I work for Centers for Disease Control and Prevention. So I'm rare in the sense that audiologist working in a public health agency. My question is, I think this is the broad question. Are you also going towards the direction of policy study in wherever you're doing? Are you going to integrate a policy angle into it?
So I can't do everything. But I would say that the closest, I guess, personally for me that I've been very interested in this is, yes, you can do all the research in the world, let's face it, right? And you won't make a lick of difference. So, I mean, that's been a lot of my work through IOM. So I co-chaired the panel last year for the IOM on that, and that's why that led to this consensus study. So I think policy will hopefully evolve very quickly from PCAST and what the IOM will come out with next year. We don't know what they're going to say yet, obviously. We don't know what we're going to say yet. But that, I think, will be where policy evolves from very quickly, hopefully. Those are only initiatives I know, the big initiatives going on right now. Within the VA, obviously, the VA is a whole another, and Lucille Beck, and I mean, they've been long aware of these issues too. But I mean, I can say personally, that's what I'm doing at least. But beyond that, the policy piece, looking at, I would say, broader questions of demonstration projects within CMS, within Medicare for different types of therapies, for treating hearing loss and what are long-term benefits. I mean, those get sort of policy issues, more research, which no one is really doing yet, unfortunately.
Then my next question is somewhat related with the hearing aid legislation, which is also policy. Okay. Now, in the newborn hearing population, this is what CDC is charged to at the other spectrum of the world. All right. In the sense of what we have been noticing in the newborn hearing screening with regarding hearing aid use is that legislation to actually cover hearing aid, it seems to us you have to be fighting it state by state, beginning at a state law. It is extremely hard from the federal level to fight that war. Okay, and it's been very successful in the newborn population to fight it state by state. A lot of states actually passed coverage for hearing aids, and some of them actually extended to adults. Mm-hmm. All right. Now, in this sense, then, so do you foresee the fact that is probably this may be replicated in the adult population, fighting it from the states to states, and how much of the PCAST is you think that it's going to influence the state legislation and politics?
I don't know.
You don't know? Okay.
Well, you have really shared so much with us today, and it is wonderful to get this data and to get this look at where we're going with the future. I know that all of us have been thinking a lot about our roles in the future healthcare system. This is very helpful and I think very clear and well thought out. So thank you, Dr. Lin.